this video, we will be discussing urinary tract infection or UTI and its management. I'll be covering the following points: UTI and its usual suspects, the type of UTIs, tests to diagnose UTIs, drugs to manage UTIs, challenges including antibiotic resistance and catheter use. Jane is a young 20-year-old woman who has always been fit and healthy. However, recently, she has been feeling very uncomfortable and embarrassed. This is because she has to go to the toilet frequently to urinate, but each time there's a burning sensation and she can only pass out a small amount of urine. She has no fever or flank pain. This is also the first time she has experienced such symptoms, but she's too shy to visit a doctor. What do you think is wrong with Jane? As you may have guessed, Jane has contracted a urinary tract infection, or usually abbreviated as UTI. Although UTIs are one of the most common infections in women, there are also some common myths and misconceptions around them. These include statements such as how one gets it due to poor hygiene, that it only affects women, and that it's a sexually transmitted disease. In this video, we will clarify and address some of these common myths and misconceptions around UTIs.
A UTI is a urinary tract infection. It's an infection of the urinary tract which extends from the kidneys down the ureters to the bladder and includes the urethra. However, some students ask, does the word UTI include sexually transmitted infections such as chlamydia or gonorrhea? And the answer is no. When we're talking about UTIs, we exclude STDs. People often think of a UTI as a simple infection, but they're not. They're very common and they're very troublesome. About 20% of women will have more than one UTI each year, and about 40% of women have at least one UTI over their lifetime. Some unfortunate people get recurrent UTIs, and a popular definition of recurrent is more than 2 UTIs every 6 months. When we talk about UTIs, we split them into different categories. We have upper UTIs and lower UTIs. The upper UTIs affect the kidneys, whereas the lower UTIs are limited to the bladder. So let's talk about the lower UTIs, the bladder infections, which we also call cystitis. We split these into simple and complicated. So if somebody has a simple bladder infection, a simple UTI of the lower tract, then this is usually in somebody who responds rapidly to treatment just for a few days. And these people don't have severe problems that cause the UTI to come back. Now this is in contrast to people who may have a complicated UTI. These people may have an anatomical reason why they're getting a UTI, or a recurrent UTI, or a reason why they don't respond well to therapy. So they may have some anatomical abnormality which prevents drainage of urine. They may have an abnormality of their nervous system that stops them draining their bladder properly. All of these things lead to difficulties in treatment, lead to recurrence of infection, and essentially lead to more resistant bacteria because these people get exposed to more and more antibiotics. So let's talk about the upper urinary tract, which involves the kidneys. These patients present very differently. This is a far more invasive infection and commonly leads to bacteremia and sepsis. Patients may have a high fever, they may have pain in their flank, they may be tender if you palpate their kidneys, and they can be very unwell. So we make these distinctions because the patients present differently and they need to be cared for differently. The most common cause of UTI is Escherichia coli, which we abbreviate to E. coli. And the second most common cause is, it's also E. coli. And the third most common cause, it's E. coli again. I say this to my students because I want to really impress on you all that E. coli outstrips any of its competitors. Yes, other bacteria can cause UTI, but E. coli is number one. So some of the other ones include Proteus, Enterococcus, Klebsiella. These are examples from the community. But if your patient has a more complicated story, let's say they're hospitalized and they've been in hospital for a while with maybe multiple courses of antibiotics, or maybe they have an indwelling catheter, or they have recurrent UTI, then we may have bred a different flora altogether. So you must think about and ask about your patient's history before you make your prediction of what you think they might have. Let's ask the question, how do the bacteria get into the urinary tract? Now, the bacteria get onto the skin around the urethral opening from the anus. The bacteria all come from the gastrointestinal tract. So we all have a little fecal flora around our anus, and a little of that flora can make its way up the urethra and into the bladder. Now, the reason that UTIs are so much more common in women is probably down to the fact that their urethra is so short. The distance from the external opening to the bladder is only a few centimeters, whereas it's much longer in men. Now, the act of passing urine flushes bacteria away, so it's thought that this simple difference in the length of the urethra may explain why women get UTIs so much more commonly than men. Now, men do get UTIs for special reasons, and women may also get more UTIs for other reasons. These include anything that disturbs the flow of urine. So this may be a functional problem, such as they're not emptying their bladder. So let's take the example of an older man whose prostate gland is increased in size. This reduces the flow of urine. It also leads to residual urine. So anything that interrupts the normal flow, especially if it leaves residual urine. Let's take a pregnant woman. They have dilatation of the urinary tract because of all their hormones that rush around dilating many parts of their body. And that leads to lower flow and residual urine. That's no different as far as the bacteria are concerned from a man with a prostate. Anything that leads to residual urine. Perhaps somebody's had a spinal cord problem and can't empty their bladder normally. Maybe somebody has a stone that prevents all the urine being emptied. Anything that causes residual urine will lead to a UTI. Let's talk about the symptoms of a urinary tract infection. Well, in somebody with a lower urinary tract, just an infection of the bladder, cystitis, they may come along complaining of pain when they pass urine. They may have lower abdominal pain. They may have frequency, which means they have to pass urine more often. And they may have urgency, which means once they have the desire to urinate, they have to go very quickly, otherwise they may lose control or leak a little bit. Now, if somebody has an infection of the upper urinary tract, of the kidneys, they have more systemic symptoms. The first one might be fever, and they feel unwell because they are systemically unwell. They may have pain in their flank on one side or the other, depending on which kidney is affected. And if the bacteria have made their way into the bloodstream, then we call that urosepsis, then they may have symptoms of general sepsis. And that may be very severe or maybe more mild. So these patients might come in confused because if they're so we see a lot of elderly people, especially elderly women, admitted with general confusion. Of course, this could be a range of causes, but UTI is top of the list. Let's talk about investigations. You may think somebody has a UTI, but you may want to confirm it. So in this patient, Jane, who we heard about earlier on, she had a urine sample sent to the laboratory. They reported Escherichia coli, as we might expect. Now, if I were her doctor, I would not have done that, because she has a clear-cut history, she's a well lady, she hasn't been treated before, so I would have treated her empirically and would not have spent her money sending a sample to the laboratory. However, if you're uncertain about the diagnosis, then the laboratory tests can help you. And the simplest one, it's cheap and cheerful, is a dipstick test. This can be done in the clinic, and it simply reports leukocytes, which are white cells, or nitrites. Now, it's not perfect. The presence of leukocytes doesn't necessarily mean there's a UTI. And the nitrites, not all bacteria make nitrites. The test isn't always positive, so it's not a very sensitive test. So overall, the dipsticks are cheap and cheerful, quick test to be done in the clinic. A more formal analysis involves sending urine to the laboratory. Now, the problem is that when you collect urine, it tends to get contaminated with fecal flora from around the urethral opening. So we want a midstream sample of urine, an MSU. So you ask the patient to pass a little urine and then collect the next portion of urine. So the chance of that urine being contaminated is far less. Now when the urine comes to the laboratory, we do microscopy. Again, we're looking for the numbers of white cells, and we do culture. The other data we give you is the antibiotic susceptibility results, and this helps you tailor your care to the results that we give you. Now Jane had a simple UTI, but other patients may have what seems to be a complicated UTI. Maybe they have a recurrent UTI. Now in a young woman who's sexually active, this may be simply related to her having sexual intercourse. And simple advice such as passing urine after sex can help reduce the number of UTIs a lady may have. However, some people do have a complicated lower urinary tract UTI. So if somebody does have recurrence that doesn't respond to simple measures as discussed already, there's something in the history that makes you suspect something else, then you may have to arrange imaging. Exactly which kind of imaging, whether it's an ultrasound or an X-ray or an MRI maybe, all depends on what you think may be going on. So for Jane, she had a simple UTI, she didn't need any of this imaging. Now your patient wants to get better as quickly as possible. Now some of the data suggests that people will get better when they have a simple UTI if you just ask them to drink plenty of water and give them a painkiller to try and deal with the pain. However, people get better faster with an antibiotic. Most patients would prefer just that. So let's talk about how we treat them. For somebody like Jane who came to you without any previous complicated history, you would give an empirical antibiotic. That means one without laboratory data to guide you. So you may choose one of the simple oral agents such as nitrofurantoin, cotrimoxazole or fosfomycin. This can often cure the patient and they only need a few days therapy, and it's as simple as that. I want to mention a few special groups, and I think men are a special group. Why? Because men don't get UTIs so commonly. Women get UTIs about 40 times more commonly than men. So if you see a UTI in a man, you should be asking yourself, does he need investigation? Have a lower threshold for investigating a man. It's not because I'm a man, it's because it's more likely that he has something severely wrong that you can correct. Now let's talk about another group, postmenopausal women. In the menopause they have less estrogen and this affects the vaginal flora. They grow far more Enterobacteriaceae. Those are colonic organisms such as E. coli, Klebsiella. So the flora around their external urethral opening is far richer in these organisms. So they are far more likely to get a UTI. That means we can intervene, we can give them a vaginal estrogen gel, which may help reduce the frequency of their recurrent UTIs. Another group who get recurrent UTI are young sexually active women. Now why does this happen? Well, it's thought that maybe a little bit of the trauma during sexual intercourse may cause trauma to the urethra, and this makes it easier for the bacteria to adhere to the urethral epithelium and to resist the flow of urine as they are supposedly washed away. What can we do about it? First thing is start simple. We advise them to pass urine after having sex. This helps to flush away bacteria from the urethra. Some ladies who have recurrent UTIs, we may put them on chronic low-dose antibiotics. We don't want to do this because it tends to lead to resistance and may have side effects, but it can be very helpful. So I just want to finish off by saying UTIs are not simple. They are life-changing, especially for a lot of women. They're really troublesome, they cause social problems, they cause marital problems. And yet most hospital doctors don't see them as that important. In the community, they just cause a lot of harm. So take them seriously. If there's any complication or uncertainty, then it's sensible to get a formal analysis done so you have results to guide you. So let's just think a minute. how many patients come to you who've already had an antibiotic recently? Many of them. You must check the history, because if somebody's had an antibiotic, and it doesn't matter what it's for, it might have been for a skin infection or a chest infection, these will all affect the gut flora, and it's the gut flora that causes the UTI. You may decide to use the same one, but you should be aware and warn the patient that it may not work. Or you may say, no, I'm going to choose a different agent because I know they've had that one recently, and they may have a resistant organism. And for a patient who's more severely unwell, especially people with an upper UTI, they would be admitted to hospital and get intravenous antibiotics. And sometimes they get a combination. Why a combination? Well, some people like to cover for enterococcus as well as the gram-negatives. Other people feel that the resistance rates in people in hospital are higher, so they want to give 2 agents, hoping that at least one of them will work. And this is the problem we have with multi-drug resistance. We end up giving more antibiotics, more expensive antibiotics, and antibiotics with more toxicity. Now, let's go back to the beginning. If we have a patient who has a causative factor, something that's made them get a UTI, such as the presence of a catheter, we should be trying to deal with that. Whether it's an indwelling catheter, or an enlarged prostate, or a kidney stone, anything that's causing the infection, we must address it, because there's only one antibiotic to which there's no resistance, and that's called a scalpel. You've got to correct the anatomy to prevent recurrence. Otherwise, our patients get recurrent UTIs, they get recurrent antibiotic prescriptions, they get more resistant organisms. And this is the cause of so many of our problems. So remember, get rid of unnecessary catheters. Try to look for and deal with any surgically correctable problem. And let's not forget that when you give somebody an antibiotic, especially a woman, you can cause side effects. Let's specifically talk about diarrhea, which is really common, and let's talk about vaginal candidiasis. Many women, after a few days of a general antibiotic, will get vaginal candidiasis. So we're trying to treat one problem and we cause another. So we must try and give as little antibiotic as we can to cure the problem. Don't give them 7 days if they only need 3.
The problem is most UTIs are resistant to many antibiotics. For example, ampicillin was once a commonly used antibiotic, has now been largely abandoned. A study done in Singapore has found significant resistance among Enterobacterial family to the commonly used antibiotics such as ampicillin, ciprofloxacin, and cotrimoxazole in primary care. The second problem is the use of long-term urinary catheters. Catheters introduce organisms into the bladder and promote bacterial colonization. 80% of UTIs that occur while in hospitals or healthcare institutes are related to urethral catheterization. There are risks in using urinary catheter without appropriate indication. So ask yourself if your patient really needs that urinary catheter. In summary, these are the learning points that you should take away from this video. UTIs are commonly caused by E. coli and is more common in females than in males. It is mainly diagnosed by dipsticks and urinary cultures. It is treated by first-line empirical drugs, but please bear in mind the antibiotic-resistant patterns. The long-term dwelling urinary catheters should be better managed. Knowing these will help you to lead to better management of UTIs and better prognosis.